Hello, my name is Ethan Munzinger. I'm an interventional cardiologist in Central Arkansas. I work at Unity Health in Searcy, Arkansas, as well as CHI St. Vincent Heart Clinic, Arkansas. The case I'm discussing today is a case of phlegmasia ceruleus dolens treated with percutaneous mechanical thrombectomy. It was particularly interesting because of the severity of our patient's symptoms as well as the rapidity with which she improved after treatment. Our case involves a 21-year-old woman with no real past medical history other than being on oral contraception. She presented to the ER for evaluation of severe pain and swelling in her left leg, and on the day of presentation, symptoms had progressed and her leg had developed a bluish discoloration. She had a leukocytosis and a positive D dimer, and of course, the diagnosis of DVT was suspected. It was confirmed with ultrasound, which showed a large occlusive thrombus burden from the left popliteal vein all the way to the common femoral vein, and of course, we suspected significant occlusive disease more proximally. Because of the severity of her condition, she was offered invasive treatment, in this case, percutaneous mechanical thrombectomy. This is a description of the procedure. The patient was taken to the cath lab and placed prone on the table. Moderate sedation was given. Access site was anesthetized with lidocaine subcutaneously. Using ultrasound guidance and micropuncture, a 5-Fret sheath was placed into the popliteal vein, and initial venography was performed, which you'll see on subsequent slides. An 035 supercore wire was advanced to the superior vena cava. The sheath was upsized to a 13 French Inari clot triever sheath. Heparin was administered to achieve an ACT greater than 250. And then in this particular case, 4 passes with the Inari clot triever were made, also shown on subsequent slides. At the conclusion of the case, we had good flow from the sheath. We took a final venogram, sheath was removed. Hemostasis in this case was achieved with manual compression. This slide shows the extent of the thrombotic burden. You can see a large thrombotic occlusion throughout the left femoral vein, more proximally into the common and external iliac vein. In this slide, we show deployment of the clot triever. The coring element is attached to a collection bag. This is unsheathed and expanded in the IVC just above the thrombus burden, and then it's withdrawn all the way through the thrombotic occlusion and recollapsed at the sheath and removed from the body. It's then cleaned and the thrombotic debris is removed. It's collapsed and reinserted over the wire. In this case, we performed 4 passes, each in a different quadrant, so the coring element was rotated approximately 90 degrees from the prior pass. This was early in our experience, and in this case, we did not actually perform intravascular ultrasound. But this is our final venogram. It shows no significant residual thrombotic burden through the femoral vein and good flow in the common and external iliac vein into the IVC. This slide shows the thrombus removed from each pass, and you can see both acute and chronic components. Our patient did quite well. She was admitted to a med-surg floor, did not require ICU admission, did not require any thrombolytics. She was up and walking the next morning. Her leg was warm and well perfused. Her color was normal. Her pain and swelling were markedly improved. She required no narcotic pain medication. She was started on apixaban and was discharged from the hospital 14 hours actually from the time she had presented to the ER. At her 1 month and 3 month follow-up, she was doing quite well, had no post-thrombotic syndrome, and had returned to all of her prior activities. Again, this case was particularly interesting for us because of the degree of our patient's symptoms as well as how quickly she improved post-procedure. Phlegmasia ceruleus dolens literally means painful blue inflammation and is the result of massive iliofemoral DVT. It has a high risk of morbidity and mortality and can progress to venous gangrene and then to death or amputation. The Society for Vascular Surgery actually recommends consideration of early thrombus removal for patients with first episode of massive iliofemoral DVT as well as for patients with limb-threatening iliofemoral venous outflow obstruction. Non-surgical treatment options include catheter-directed thrombolysis, pharmacomechanical thrombolysis, and percutaneous mechanical thrombectomy. Each has its pros and cons. Catheter-directed thrombolysis often requires admission to the ICU, can be associated with increased risk of bleeding, and often requires a trip back to the cath lab for subsequent studies. Pharmacomechanical thrombolysis is associated with a higher risk of major bleeding compared to anticoagulation alone. And then percutaneous mechanical thrombectomy, such as with ClotTriever, avoids ICU stay and the use of thrombolytics. Early data from the CLOT registry has shown no bleeding events or major procedure or device related adverse events. And in this case, we have demonstrated a strategy for a safe, effective treatment of massive iliofemoral DVT causing phlegmasia ceruleo-dolens with percutaneous mechanical thrombectomy. Thank you.